Buenos días, yo soy el doctor Alan Burguete de la Universidad Autónoma de Nuevo León y pues bueno, vamos a continuar con el programa académico pues bueno, vamos a continuar con el tema del colangiocarcinoma. Sabemos que es una enfermedad que hasta hace poco empezamos a conocer un poco más del panorama molecular y cómo vamos a empezar a integrar estos nuevos tratamientos en las líneas principales de tratamiento. Entonces, para eso quisiera pedir al doctor Abu Alfa del Memorial que nos acompañe para esta excelente plática.
All right, thanks again. Thanks for the introduction. We're back to where we should be, and we'll carry on with the discussion on cholangiocarcinoma, because I know I'm the only thing holding between you and lunch, so we'll work on that. So anyway, these are my disclosures again, and these are my contacts. Thanks if you would like to take a picture, or I'm happy to give it to you afterwards. And we'll touch on a few components, and already Dr. Crane spoke about a few of them, but nonetheless, in regard to epidemiology, I'm going to simplify it to simply one picture. And if anything, I urge everybody not to look at the disease anymore from the anatomical perspective, gallbladder, intrahepatic, extrahepatic cholangiocarcinoma. I think we have to look at it from the molecular perspective. No doubt it does follow the same setup as the anatomical one, but of course there could be some variations here and there. And if anything, now we can see that certain mutations or genetic alterations are applicable to specific disease. For example, Fgr2 Fusion in regard to intrahepatic cholangiocarcinoma, IDH1 mutation in regard to intrahepatic cholangiocarcinoma, HER2 in regard to gallbladder, and many others. The interesting thing is that what we have reported is that there is a certain mutual exclusivity. In other words, when the tumor has a mutation of IDH1, it will not be able to get a fusion protein of FGFR2, and vice versa. So this gives you a lot of guidance in regard to what the tumor potential targets are, and same time give you guidance in regard to what the potential location of the tumor is. With this setup, assuming that, of course, surgery is the primary endpoint for a curative intent, no doubt that adjuvant therapy come into play. Already, Dr. Crane spoke about this WALK 0809 study. I would say we were part of it. No doubt it has value. Understandably, however, it could not follow further beyond the phase 2 trial that was part of it. And if anything, it really keeps the question of radiation component is still yet to single applicability or a single site experience or even preference based on the extent tumor, as with some of the guidance that Dr. Crane has offered us. And of course, you also spoke about BILCAP, which again was the capstabine. I would say that BILCAP, yes, was positive, but it really brings a lot of doubts, because as you can see from the magnitude of how improved the outcome it is in the adjuvant setting, it didn't really pan very well in that regard. And if anything, really, one of the perspectives that we're bringing on is really adjuvant therapy the right approach in regard to biliary tumors? And if anything, based on this recurrence-free survival, I bring a good example about something that we're proud just got approved is in regard to gallbladder cancer. And if anything, we now know that based on the extent of the tumor, based on lymph node status, as well as the potential of a positive margin, incidental gallbladder itself can even be a problem per se. And as such, we're bringing for the first time collectively the group, the approach of what we call a peri-adjuvant therapy. In other words, therapy that you give before surgery and after surgery. And if anything, it will include, in other words, a quote-unquote new adjuvant plus adjuvant. This trial that you're seeing over here for the SWOG study of incidental gallbladder. This is a great work of our good colleague Shishir Maitel, who is a surgeon trained at Memorial now at Emory. And this was already approved by the NCI steering committee last week, and we look forward to see this study ongoing. Along the same line, there has been proposals for a peri-adjuvant approach that currently are being looked at. So I would say that still the adjuvant question is still not fully answered, and we have to look for more data. With that quick review, let me spend a little bit more time on the chemotherapy and the targeted therapy. In regard to chemotherapy, I think we all agree that the standard of care is the gemcitabine plus cisplatin based on the ABC02 study out of the UK. And if anything, we are all, using this approach as a optional therapy for our patients. And if anything, we are delighted with the positive outcome of the study, including the progression-free survival. Even though here, we have to remember that the progression-free survival is dependent on when do you measure the radiologic outcome of the therapy. And in the UK, they do CAT scans on less frequent basis, and that's why, if anything, the progression-free survival is rather very close to the overall survival. We're not sure if this is gonna ultimately pan out in one way or the other. We have to wait until we see the current data, which was published already for JAMA Oncology by our colleague when she was, Dr. Schraff, when she was at MD Anderson, looking at gemcitabine, cisplatin, and nab-paclitaxel, which, as we know now, currently is a phase 3 trial run by the NCI in the US, looking at gemcitabine, cisplatin, nab-paclitaxel versus gemcitabine, cisplatin. We just have to wait and see. So by all means, we would not recommend to use this out of the clinical trial yet. I on purpose did skip on the ABC06 because all of you are hungry, including me, but at the same time because I would say the ABC06, which is gemcitabine, FOLFOX therapy after gemcitabine cisplatin, is still debatable in regard to really the prior exposure to platinum. What does it mean? Who are those patients? I would say until the manuscript come to further analyze it per se. But I would say the most important is to talk about the targeted therapy, and there's a lot to talk about over here. If anything, we'll start with IDH1. IDH1 is a very intriguing antimetabolite component that we all have in our body, and if anything, the mutated IDH1 will actually be a pro-oncolytic component that will stop this normal process from ongoing per se. And if anything, in early efforts, there was quite a bit of focus on glioblastoma, but ultimately cholangiocarcinoma kind of start showing some intriguing components, enough that we did the Clarity study that we proudly just presented at ESMO in Barcelona in last year, 2019, looking at the ivosidenib, which is the mutated anti-MDH1 IDH1 therapy versus placebo, in a intriguing design where patients can cross over from the placebo to the ivosidenib if they were to show progression. And as such, it limits us as such for the progression-free survival as a primary endpoint because overall survival will be kind of, mistakenly read because of the crossover. Nonetheless, for the primary endpoint, as you can see, there was a clear difference in favor of the ivosidenib. And interestingly, if we look at the overall survival and using a certain technical maneuver in statistics that will pretend that patients on the placebo remained on the placebo, we can see that, yes, there was a benefit for those patients as well. We do anticipate that ultimately this drug, and we hope, will be approved by the FDA, and we'll wait until then for that purpose. The drug of note is available in the market because leukemia has a drug already applied for, and if a patient has a mutation, I can understand totally why we'll try to obtain the drug. The other thing that I would like to talk about is the Fgr2 fusion. These are rather very intriguing fusion proteins that will kind of, occur because of the lack of the inhibitory alteration that will prevent that fusion from occurring. And if anything, if you might recall, Fgr2 was the first that we published collectively, all of us together in JCO a while ago, has shown really incredible response. There was concern about the adverse events, especially the hyperphosphatemia. I would say now we have a better understanding about that the hyperphosphatemia is not really about the number, but rather about symptomatology. And as such, one of the things that erroneously we did is to make hyperphosphatemia a problem by itself, a hypophosphatemia. So try to kind of gauge it in regard to where the patient stands symptom-wise before trying to normalize that hyperphosphatemia altogether. A very important point, and this is something that I think is going to carry on more interest as we move forward. Patients might, of course, progress on the anti-FGFR2, including the Fgr2. This is great work that happened at MGH in Boston, and give them a lot of credit. If anything, patients who really progressed, and ultimately they may even have succumbed to the disease, they went ahead and actually did biopsies of the tumor that progressed. Actually, they even did autopsies of those specific tumors. And if anything, they found that actually genetic alterations do occur in a way that can bring in a certain other alteration to the FGFR2 fusion, different from the one that patients started with. What we're working on with them now, and we're collaborating with them, is trying to understand the pathway for this. Is it really totally haphazard, or is it what we call a fractal and what we call the chaotic theory in mathematics that imply that we know very well what the sequence of events will be for a specific alteration? We're working on it. We'll see where this might take us. And of course, couldn't but talk about the Fight 202 study, which the Peri-Adjuvant, the other anti-FGFR2, that was looked at in regard to FGFR2 fusion protein specific, other alterations or irrespective of alterations. And the focus was mainly the cohort A, the FGFR2 fusion. And you can see these numbers. I don't need to answer more than what you're seeing in regard to the amazing responses that we have seen on patients. Add to a critical improvement in regard to the progression-free survival in that phase 2 trial, and also in regard to the overall survival. I think these numbers talk for themselves, but the 21-month overall survival on Peri-Adjuvant is definitely something to look at very carefully and very positively. Without declaring any more than what's in the public, but the manuscript will be available to you hopefully in the next weeks or two. And number two is this is already in negotiation with the FDA for approval based on that phase 2 data. So short of the FGFR2 and the IDH1, the pembrolizumab has been looked at. Already we heard about some comments in regard to pancreatic cancer and those diseases which are really not receptive to the response to the checkpoint inhibitors. But nonetheless, we have seen a rather intriguing response, and this is really where I would say that further analyses from that perspective could be working. One of the things that Dr. Crane, myself, and our colleagues have been working on is actually looking at the abscopal effect by radiation therapy and ultimately adding the checkpoint inhibitor afterwards. We probably have some cases that did extremely well, and this is now moving hopefully into a clinical trial setting. And MSI story, of course, we spoke about it quite a bit, and I think I don't need to repeat it per se, but please do remember, yes, we are obligated to do it for patients, but we have to really put it in perspective that these will be less than 4% of the patient with cholangiocarcinoma that will have an MSI high tumor. Nonetheless, of course, if they have it, definitely go for the appropriate therapy. I would say that to conclude, peri-adjuvant therapy work is evolving. Happy to see the work of Dr. Maitel now is approved and will move forward in regard to gallbladder cancer. Hopefully this will be followed by another effort at the Alliance. Gemcitabine cisplatin is still the primary choice of therapy. The nab-paclitaxel addition is yet to be finishing the trial, and we'll see what's going to tell us. FOLFOX, I would say, in second line is still we would like to see more details from the manuscript, hopefully. The mutated IDH1, now we have a drug, ivosidenib. For the anti-FGFR2, we have two drugs, the pemigatinib and the infigratinib, and we are anticipating the pemigatinib will be looked at by the FDA based on the phase 2 trial. And by the way, the two drugs are being looked at in phase 3 trial versus gemcitabine cisplatin. We decided to do a strong collaboration with MD Anderson on this because we felt like we need an answer quickly rather than lose effort because this is not a common alteration, at best maybe 5% of the patients. So the effort on the infigratinib is a collaborative effort between MD Anderson and Sloan Kettering, and we're hoping that we'll have the rapid accrual needed for that purpose. And of course, immunotherapy, as I mentioned, we can apply it in regard to certain specific patients, like, for example, the MSI high, but of course, we need to look more into that potential combination with radiation therapy, as I mentioned. So I'll stop here. Thank you very much again. Thank you.